Real-life nurses, stories, hospice nurse story, unexplained medical case, true, hospital stories, doctors and nurses stories. Pediatric hospice, care medical mystery story, end of life. Care real story, true healthcare stories, limits of medicine. Noi dung. I've helped hundreds of people die peacefully. I've stood beside beds where breathing slowed. Monitors went quiet, and families whispered their goodbyes. But I was never supposed to watch a child die like this. I'm a hospice nurse practitioner. I've been doing this work long enough to know the difference between a medical emergency and the natural end of a life. Hospice is not a hospital. We don't run codes. We don't chase lab results. We don't look for miracles. Our job is comfort, dignity, and honesty. Most nights, nothing surprising happens, and that's exactly the point. That night started the same way. It was just after 7 p.m. when I walked into Willow Creek Hospice Center, tucked into the quiet hills outside Asheville, North Carolina. Winter evenings, they're calm in a way hospitals never are. No sirens, no overhead announcements. Just low lights, soft voices, and the steady rhythm of people slowing down. I signed in, checked the board, skimmed the notes from the day shift, and poured myself a cup of coffee I knew I wouldn't finish. I remember thinking it would be an easy night. A few medication adjustments, a family meeting in the morning. Maybe one patient who wouldn't make it through dawn, but nothing dramatic. Hospice doesn't do dramatic. Then I saw the new admission listed at the bottom of the board. Age 5. That stopped me. Children don't belong in hospice. Not because it never happens, but because when it does, everyone feels it. Pediatric hospice cases are rare, and when they show up, they change the tone of the building. The staff speaks more carefully, the halls feel narrower, even the silence sounds different. The chart said his name was Caleb Morgan. Diagnosis, advanced neurodegenerative disorder, genetic progressive, no curative treatment. Referred after multiple hospitalizations, and a long conversation that ends the same way every time. There's nothing more medicine can do except make sure he isn't in pain. I stood there longer than I meant to, reading and rereading the intake summary. 5 years old, fully conscious. No severe pain at admission. Prognosis, uncertain but limited. Expected course decline over days to weeks. That was normal on paper. It still didn't feel normal. I went down the hall to the room that had been prepared for him. Smaller bed. Extra space for parents. A box of toys someone had placed on the windowsill, probably without thinking too hard about it. You don't want to think too hard about it. Caleb arrived around 8:30 with his parents. His mother carried him in, not because he couldn't walk, but because he was tired. His father followed quiet, holding a backpack and a blanket. They looked like people who had learned how to hold themselves together in public and were running out of energy to keep doing it. Caleb was smaller than most 5-year-olds, thin in that way kids get after months of being sick. But his eyes were open, alert, curious. He looked around the room like he was taking inventory, not scared, just observant. I introduced myself and explained what hospice was, even though his parents already knew. People always want to hear it again just to make sure nothing has changed. Comfort, support, no aggressive interventions. They nodded. His mother asked practical questions about medications and visiting hours. His father didn't say much. Caleb listened. That caught my attention right away. Most kids his age drift off during these conversations. He didn't. He watched my face like he was following along, even when the words were clearly for the adults. When I finished, he asked if he could keep the stuffed dog tucked under his arm. I told him, of course. From a clinical standpoint, nothing about him alarmed me. His breathing was steady, heart rate appropriate, no signs of distress. He wasn't in pain. If I had seen him in a hospital room instead of a hospice bed, I might have thought he was stable enough to go home. That's what made this uncomfortable. Hospice works best when the body is clearly shutting down, when the trajectory is obvious, when everyone, including the clinician, understands what comes next. Caleb didn't fit that picture. He was sick, yes, but he was still very much present. As I finished my assessment, I caught myself doing something I usually don't do. I started thinking ahead, not planning medications, planning explanations, how to answer questions if things didn't unfold the way the textbooks describe. That was the first sign I should have paid more attention to. Before I left the room, Caleb looked at me and asked if people stayed here all night. I told him yes, nurses were always nearby. He seemed satisfied with that answer. I stepped back into the hallway and felt that familiar professional reflex kick in. Don't overthink it. This is hospice. Trust the process. You've done this before, still. As I walked back to the nurse's station, I glanced at the clock and realized I was hoping the night would go quickly. That's not something I usually hope for. Right then, before anything else happened, let me pause for a second. If stories from hospitals, hospice, care, and real nurses' experiences matter to you, take a moment to leave a comment below and let me know where you're watching from. And if you want more real-life nurses' stories like this one, go ahead and subscribe to the channel. It helps more than you think. I didn't know it yet, but that quiet room at the end of the hall was about to challenge everything I believed about hospice care. At that moment, all I knew was that a 5-year-old child had arrived in a place designed for endings, and nothing about him felt like it was already ending. I stayed at the nurse's station longer than usual, staring at Caleb's name on the board while my coffee cooled untouched beside me. Eventually, I closed the chart, stood up, and walked back down the hall, telling myself that hovering didn't help anyone. His room looked the same as it had 20 minutes earlier. Soft light, curtains half drawn. His parents sitting on either side of the bed, their bodies angled inward like they were protecting something fragile between them. Caleb lay on his back, the stuffed dog still tucked under his arm, eyes open and focused on the ceiling. I asked how he was feeling. He shrugged in a way that felt older than 5. From a hospice standpoint, the admission was straightforward. No IVs, no monitors, comfort medications ordered as needed. Clear instructions to the family about what symptoms to watch for and when to call us. This wasn't their first medical conversation. They knew the language, they asked smart questions. They didn't ask for miracles. His mother asked if it was normal that he wasn't in pain yet. I told her yes. Sometimes children with neurological conditions don't experience pain the way adults expect. Sometimes the decline is quieter, slower, less dramatic than people imagine. She nodded, but I could see the tension in her jaw. Parents don't relax when you tell them things are normal. They relax when they feel understood. Caleb interrupted us to ask if he could sleep with the hallway light on. Not bright, just enough so the room didn't feel completely dark. I told him that was fine. We could leave the door cracked too. As I adjusted the light, I noticed how aware he was of every movement. He watched my hands. He tracked the sound of my shoes against the floor. There was no confusion in his eyes. No fog. If anything, he seemed more present than most of my adult patients. That didn't line up neatly with the diagnosis in his chart. I finished documenting and stepped out to update the on-call physician. The conversation was brief. Pediatric hospice cases always are. There's rarely anything to change on day 1. We agreed to keep medications minimal and reassess in the morning. No red flags, no urgent concerns. That should have been reassuring. Instead, I felt unsettled in a way that was hard to explain. It wasn't fear. It was the sense that I was standing in the wrong place for what was happening, like reading familiar script with one line out of order. I checked on my other patients, moved through the usual routines, answered a call from a family member in another wing who wanted reassurance that breathing patterns were normal. By the time I circled back to Caleb's room, the hallway was quieter, the building settling into its nighttime rhythm. His father had stepped out to make a phone call. His mother sat beside the bed, one hand resting lightly on Caleb's shoulder. She asked me quietly how long this usually takes. That question is never about time. It's about control. It's about whether there's still room to prepare. I told her the truth. With children, especially with neurological conditions, it's hard to predict. Sometimes days, sometimes weeks. Sometimes the body surprises us. She nodded again, but this time her eyes stayed on her son. Caleb shifted slightly and asked if people ever stay with patients when it's quiet at night. I assumed he meant staff volunteers, maybe family members who can't sleep. I told him yes. Someone is always close by. He seemed to think about that, then said, "Okay." The way he said it made me pause. It wasn't relief. It was confirmation, like he'd been checking something off a list. His mother looked at me, searching my face. I smiled, the calm, professional expression I've perfected over years of practice. Inside, my thoughts were less composed. I reminded myself that children ask strange questions when they're tired. That awareness doesn't always mean understanding. That this was still hospice, still familiar territory. Before I left the room, I asked if they needed anything. Water, blankets, extra pillows. They said no. I stepped back into the hallway and closed the door quietly, leaving it cracked the way Caleb had asked. As I walked away, I noticed something else that didn't fit. The usual sounds of hospice at night were there but muted. No coughing, no labored breathing, no call lights blinking insistently. It was too calm. I went back to the nurse's station and reviewed Caleb's history again, slower this time. The progression, the hospitalizations, the genetic testing that had led to more questions than answers. I didn't see anything new, but I found myself reading between the lines, looking for patterns, that might explain why he didn't look like a child. Nearing the end of life, that was when I caught myself doing something I rarely do during an admission. I started thinking like a hospital clinician instead of a hospice one. What would I order if he were upstairs on a pediatric floor? What would I monitor? What questions would I ask that hospice doesn't usually need answers to? I pushed those thoughts aside. Hospice care requires a different kind of discipline. You don't chase every possibility. You focus on what's in front of you. Still, I made a note to check on him again before midnight, even though there was no clinical reason to do so. It wasn't protocol. It was instinct. When I returned to his room later, the light was still on. The door still cracked. His father was back, sitting quietly, his hand wrapped around Caleb's small foot like an anchor. Caleb was awake. He looked at me as soon as I entered, like he'd been waiting. Not urgently, not anxiously, just aware. I asked if he was comfortable. He nodded. I asked if anything hurt. He shook his head. Then he asked if the night was almost over. I told him it wasn't quite there yet, but morning would come. It always does. He seemed satisfied with that answer, too. As I stood there, chart in hand, listening to the soft sound of his breathing, a thought settled in my chest that I couldn't quite name. It wasn't panic. It wasn't dread. It was the uncomfortable realization that this case was already pulling me out of my usual rhythm. Hospice cases usually teach you patience. This one was teaching me to pay attention. I didn't leave his room right away. I stood there longer than necessary, pretending to reread my notes, while watching the slow rise and fall of Caleb's chest, trying to convince myself that the unease in my stomach was just fatigue settling in. Hospice teaches you to trust patterns. When you have seen enough deaths, you stop reacting to every deviation. You learn what matters and what doesn't. Caleb's vital signs didn't matter. His labs didn't matter. What mattered was comfort, and by every measurable standard, he was comfortable. And yet nothing about the way he looked at me felt routine. I asked his parents if he'd been sleeping earlier in the evening. His mother said he'd dozed off for a bit, then woken up on his own. No confusion, no agitation, just awake. That stood out. Most children this sick don't wake easily. They drift. They fade in and out. Caleb didn't drift. He seemed to arrive fully each time he opened his eyes. I adjusted his blanket mostly to give my hands something to do and asked him if he wanted to rest. He said he wasn't tired yet. His father smiled weakly and said he'd always been like that, stubborn about bedtime even when he was healthy. The comment was meant to lighten the moment. It didn't quite land. I stepped back, gave them space, and returned to the station. The clock read 11:17 p.m. The building felt even quieter now, the kind of quiet that makes you aware of your own breathing. I pulled up Caleb's chart again, this time not reading for information but for reassurance. Diagnosis confirmed. No acute complications documented. No seizure activity reported recently. No signs of infection. Everything pointed to a slow decline. The problem was that nothing I was seeing suggested decline at all. When I checked on him again around midnight, his parents were whispering to each other. Caleb's eyes were closed, but he wasn't asleep. I could tell by the way his eyelids moved, tracking something I couldn't see. I asked if everything was okay. His mother hesitated, then said he'd been talking a little while ago, talking how she glanced at him before answering like she didn't want him to hear. She said he'd asked if it was normal for people to stand in the room at night and not say anything. I felt my posture change, without thinking. Not fear. Attention. I asked her what she told him. She said she told him sometimes nurses check in quietly, sometimes parents watch while kids sleep. That seemed to satisfy him. I nodded, keeping my expression neutral. Children ask questions like that all the time. Imagination, anxiety, fatigue, none of it was unusual. Still, when I leaned closer to adjust the monitorless bedside setup, Caleb opened his eyes and looked directly at me. "They're here now," he said. His voice wasn't hushed. It wasn't excited. It was conversational, like stating a fact. I asked who he meant. He looked past me, toward the corner near the chair. The people who come when it's quiet. His parents froze. I could feel it in the air that moment when adults decide whether to panic or wait for the professional in the room to set the tone. I didn't react. I asked him what they were doing. He shrugged, just standing. I asked if they scared him. He shook his head. "No, they don't do anything." I glanced at his parents, then back at him. Hallucinations aren't rare. In sick children, especially at night. Visual misperceptions happen when brains are under stress. None of this on its own required intervention. What bothered me was how grounded he seemed while saying it. There was no confusion in his speech, no disorganization, no emotional distress. He wasn't frightened. He wasn't seeking reassurance. He was reporting. I told him it was okay, that sometimes our minds make up things when we're tired, and that he was safe. He nodded, not arguing, not insisting, just acknowledging the information. When I left the room, his mother followed me into the hallway. She asked if that was something to worry about. I told her what I believed to be true. Children with neurological conditions can experience sensory changes. Fatigue and illness can blur the line between imagination and perception. What mattered most was whether he was distressed or uncomfortable. He wasn't. She listened carefully, then asked a question that caught me off guard. But if he's not confused, why does it feel like he knows something we don't? I didn't have a clinical answer for that. I told her gently that children often process illness differently than adults, and that meaning doesn't always come from understanding. She nodded, but I could tell the explanation hadn't landed the way she needed it to. Back at the station, I found myself documenting the interaction in more detail than usual. Exact wording, exact tone. I told myself it was just good practice. In truth, I wanted a record, in case my own memory later tried to smooth over something that felt sharp in the moment. As the night wore on, Caleb didn't deteriorate. He didn't grow restless. He didn't call out. He slept for short stretches, waking calmly, asking simple questions, then settling again. Each time I passed his door, I glanced in. Each time he looked peaceful. That was the problem. Hospice deaths are rarely peaceful from the beginning. There is usually a period of struggle, of visible effort, of the body failing in ways that are obvious even to untrained eyes. Caleb's body wasn't struggling. It was holding steady. At 2 a.m., I sat down with his chart again, not because there was anything new to add, but because I couldn't shake the feeling that I was missing something important by doing nothing. Hospice work trains you to resist that impulse. Action is not always care. Sometimes restraint is the most ethical choice. Still, I wrote myself a reminder to reassess his comfort plan in the morning, even though nothing indicated it needed changing. When I checked on him just before 3 a.m., his father was asleep in the chair, head tilted back, mouth slightly open. His mother rested against the side of the bed, eyes closed, one hand still on Caleb's shoulder. Caleb was awake again. He looked at me and smiled faintly, the kind of smile children give when they recognize someone they trust. They said it's okay if I sleep, he told me. I asked who said that. He didn't answer right away. He just looked comfortable with the idea, like it didn't need further explanation. I asked if he wanted me to stay for a minute. He shook his head. You're busy. I stepped out of the room feeling something shift inside me, subtle but unmistakable. This was no longer just a pediatric hospice admission. This was a situation asking for attention in a way hospice cases rarely do. As I walked back down the hallway, I realized I had stopped trusting the predictability that usually grounds my work. I didn't know yet what that meant, only that whatever was happening with Caleb wasn't following the patterns I relied on to keep myself steady. And that made me pay closer attention to every quiet moment that followed. I stood at the medication cart longer than I needed to, fingers resting on the edge, staring at orders that hadn't changed since admission. Everything on the list made sense. Low-dose comfort meds, nothing scheduled aggressively, nothing meant to sedate. On paper, this was exactly how pediatric hospice care is supposed to look. In practice, it felt unfinished. Hospice medicine lives in gray areas. There's no algorithm that tells you when comfort becomes avoidance or when restraint becomes neglect. You weigh suffering, you can see against suffering you're trying to prevent. With adults, experience fills in the gaps. With children, the gaps feel wider. Caleb wasn't asking for medication. He wasn't restless. He wasn't grimacing or guarding his body. From the outside, there was no justification to intervene. And yet, I kept replaying the way he spoke, the calm certainty behind his words, the absence of fear, where I expected at least some. I reviewed the standing orders again, then pulled up the hospice guidelines we use for pediatric patients. They were familiar, reassuring in their clarity. Start low, increase slowly, prioritize alertness when possible, preserve meaningful interaction, all the things I believed in. The problem wasn't the guidelines. It was the space between them and the child in the room down the hall. I walked back to Caleb's room just after 4 a.m. His parents were awake now, sitting quietly, not speaking, as if conversation might disrupt something fragile. Caleb lay still, eyes closed, breathing steady. He didn't stir when I entered. I checked in softly, asking how the night had been. His mother said it had been calm. Too calm, she added. Then apologized immediately, as if calm were something to be grateful for, not questioned. I asked if he'd seemed uncomfortable at any point. She shook her head. She said he'd woken a few times, said a few things that didn't make much sense, then gone back to sleep. Her words mirrored my own thoughts, which didn't help. I stepped back into the hallway with his father while his mother stayed by the bed. He asked carefully whether this was normal. Not the talking, the stillness. I told him the truth. There's a wide range of normal at the end of life, especially with neurological conditions. Some children decline loudly, others quietly, neither predicts timing very well. He nodded, absorbing that, then asked the question I'd been avoiding. Should we be giving him more medication just in case? That question is the ethical center of hospice care. Just in case of what pain that hasn't arrived, fear that may never come, or something we can't name but feel responsible for preventing, I explained our approach. That medication is meant to treat symptoms we can identify, not possibilities. That over-medicating can take away moments families later realize they needed. That keeping him comfortable doesn't mean keeping him asleep. He listened without interrupting. When I finished, he said he trusted us. But his face said something else, and it said he was afraid of making the wrong choice by agreeing with me. I carried that with me back to the nurse's station. As morning approached, I considered calling the on-call physician again. Not because anything had changed clinically, but because my confidence had. Hospice work relies heavily on clinical judgment, and mine felt unsteady. I reviewed Caleb's comfort plan one more time, line by line. No signs of pain, no respiratory distress, no agitation. Increasing medication without indication would have been a decision driven by my discomfort, not his. That mattered. Still, I adjusted the PRN parameters slightly, not increasing doses, but making it easier to respond quickly if something shifted. It was a compromise I told myself was reasonable. Prepared, not presumptive. When I went back to his room, Caleb was awake again, staring toward the doorway. He smiled when he saw me, small and brief. I asked how he felt. Okay, he said. I asked if anything hurt. No, I asked if he felt scared. He shook his head like the idea hadn't crossed his mind. I told him that if anything changed, if anything felt uncomfortable, he could tell us, that we were there to help. He nodded, then asked if it was my job to make sure things stayed quiet. The question caught me off guard. Not because it was frightening, but because it cut straight to the core of hospice care, in a way I rarely hear spoken out loud. I told him yes, that was part of my job. He seemed satisfied with that answer. He closed his eyes without prompting, as if the conversation had resolved something. I stood there for a moment, listening to his breathing, aware of how calm the room felt. Calm can be a gift. It can also be deceptive. By the time the day shift arrived, I had already decided to stay longer than scheduled. Not officially. I didn't clock overtime. I just didn't leave. I wanted to see the morning assessment through. I wanted continuity, even though hospice prides itself on smooth handoffs. When the oncoming nurse asked if there were any concerns, I paused before answering. I could have said no. That would have been technically accurate. Instead, I said that this was a pediatric case that required attention, even though everything looked stable. She understood immediately, no further explanation needed. As the morning light filtered in through the windows, Caleb remained much the same, awake, calm, present. His parents took turns stepping out for coffee, stretching brief moments of normalcy that felt borrowed. I spoke with the physician later that morning, presenting the case without drama, sticking to facts. The calm night, the absence of pain, the unusual level of awareness. We agreed to continue the current plan with vigilance. That word stayed with me. Vigilance. Hospice is often described as passive care. It isn't. It's deliberate restraint. It's choosing not to act when action would serve the clinician more than the patient. I believe that. I still do. And yet, as I watched Caleb lying quietly between his parents, not declining in any visible way, I felt the weight of every decision not made, every medication not given, every assumption about how this was supposed to unfold, pressing in on me. The ethical balance I usually trust felt less stable, like standing on ground that looked solid until you shifted your weight. I noticed the change in his voice before I noticed anything else. It wasn't louder or weaker. It was steadier, like he'd settled into a rhythm that didn't require effort. Caleb was awake again when I checked on him mid-morning, his parents sitting close, speaking in low tones about practical things. Food they hadn't eaten, messages they needed to return. Normal conversations that felt slightly out of place in a hospice room. When I asked how he was feeling, he answered without hesitation. Still okay, still not hurting. I believed him. That's the thing people don't understand about hospice work. You don't assume patients are lying or minimizing. You learn to trust what they tell you unless their body says otherwise. Caleb's body wasn't contradicting him. What caught my attention was how deliberate he'd become with his words. He didn't ramble, he didn't trail off, he spoke like someone choosing what mattered. His mother mentioned that he'd been asking questions earlier that morning. Not medical questions, conceptual ones. What happens when people sleep for a long time? Whether quiet is different from silence, if it's possible to be awake without opening your eyes. She laughed softly as she told me like she wasn't sure whether to be impressed or unsettled. I didn't laugh. I listened. I asked Caleb what he meant by quiet. He thought for a moment, then said, "Gwas, when things stop needing your attention, when nobody's worried, when you don't have to answer questions." That answer landed heavier than I expected. I told myself again that children often use language in ways that sound profound because adults attach meaning to it. That interpretation isn't the same as intention. Still, the clarity in his tone made it hard to dismiss. His father asked if children ever know when they're dying. The room went still. I took a breath before answering. I said that children experience illness differently, that they often sense changes in their bodies before adults do, but that awareness doesn't always mean understanding death the way grown-ups define it. It was a careful answer, honest without being absolute. Caleb listened, then said he didn't think about dying. He said he thought about resting, about being done with being tired. That was when I felt something tighten in my chest, sharp and immediate, not fear or recognition. Burnout teaches you how to compartmentalize. Hospice teaches you how to sit with things that don't fit neatly into language. This moment required both. And I felt myself slipping between them. I asked if he felt tired right now. He nodded. Then he added that it felt like the tired you get when you've already finished everything you need to do. I wrote that down later exactly as he said it because I knew if I didn't, my memory would soften it, make it less specific, less unsettling. His parents didn't interrupt him. They didn't redirect. They let him speak, which told me they'd been hearing things like this already. His mother asked me if it was normal for children at the end of life to talk like this. I told her there's no single normal. Some children become withdrawn, some become restless, some talk more, some say very little. The brain processes endings in unpredictable ways, especially when neurological disease is involved. She nodded, but I could tell she was filing his words away the same way I was knowing they might matter later in ways we couldn't see yet. As the day went on, Caleb slept more, but when he woke, he was still oriented, still calm, still watching the room like it was familiar territory. At one point, while his parents stepped out to speak with the social worker, he asked me if people ever worry too much about the wrong things. I asked what he meant. He said people worry about pain, but pain isn't the hardest part. He said the hardest part is when everyone looks at you like you're fragile, even when you're not. That one stopped me completely. Children his age don't usually have the language to articulate that kind of observation. Not unless they've spent a long time being observed, evaluated, handled carefully. I told him we try not to forget that people are more than their illnesses. He said he knew. Later, as I updated his chart, I caught myself rereading my notes, half expecting to see my own discomfort reflected back at me in clinical language. It wasn't there. The words looked neutral, professional, safe. The reality felt less controlled. By late afternoon, his parents noticed he was sleeping longer stretches. When he woke, he seemed content to listen rather than talk. He squeezed his mother's hand. He watched his father pace the room. When I checked in again, he asked if I thought people could rest without being alone. I told him I thought people could be together even when they weren't talking. He smiled at that, eyes half closed, like the answer matched something he'd already decided. As evening approached, I spoke with the physician again. We reviewed everything. No new symptoms, no distress, no reason to change the plan. I agreed with the assessment. I also felt the growing weight of responsibility that comes with doing nothing when something feels significant, but undefined. Hospice work doesn't reward overreaction. It punishes it. Acting without cause can take away the very moments families are trying to preserve. Still, as I watched Caleb rest between his parents, I felt the pull of a different kind of vigilance. Not about medications or vitals, but about presence, about paying attention to what was being said, and just as importantly, how it was being said. That evening, as the lights dimmed and the building settled back into its nighttime quiet, Caleb opened his eyes and looked directly at me, and I think it's almost time, he said. I asked him what made him think that. He shrugged, a small, tired motion. Everything feels finished. There was no drama in his voice, no sadness, just certainty. I told him it was okay to rest whenever he wanted, and that his parents were right there. He nodded, then said something I haven't forgotten since. You don't have to worry so much, he told me. You're doing it right. I didn't know what to say to that. Professionals aren't trained to be reassured by patients, especially not children. I smiled, thanked him, and adjusted his blanket. But as I stepped back, I realized something had shifted. The questions I'd been carrying weren't just about hospice protocols anymore. They were about whether calm acceptance can sometimes look indistinguishable from readiness, and whether knowing the difference is even possible in real time. That thought stayed with me, As the room grew quieter, the kind of quiet that no longer felt neutral, but deliberate, I checked the clock without meaning to. Just past 10 p.m., night shift officially began to settle in the hour, when hospice rooms either grow restless or sink deeper into stillness. Caleb's room did the latter. The lights were dim now, lower than before, casting soft shadows that didn't move much. His parents sat quietly, no longer talking, just existing in the same space. Caleb lay on his side, the stuffed dog pressed lightly against his chest, his breathing slow and even. Nothing about the room suggested urgency that should have reassured me. Instead, it sharpened my focus. I stepped in and asked how he was doing. His mother said he'd been sleeping for a while, waking briefly, then settling again. No pain, no distress, no change she could point to. I approached the bed and watched him for a full minute before touching anything. His breathing pattern was regular. No pauses, no gasping, no shallow effort. His face was relaxed, not slack, not tense. He looked like a child taking a nap after a long day. Hospice deaths rarely look like that. Usually there is a progression. Breathing becomes uneven, muscles tense, restlessness creeps in. Family members sense something is coming before the monitors would ever show it. There is movement, sound effort. Caleb showed none of it. I adjusted his blanket and checked in with his parents again, asking questions I already knew the answers to. Pain, anxiety, discomfort. Each time the answer was no. His father asked if this meant the medications were working. I told him yes, they were doing what they were meant to do. That answer felt technically correct and emotionally insufficient. I stepped out to the hallway and spoke briefly with the on-call nurse, sharing my observations. Calm, stable, unchanged. We agreed to continue monitoring closely. No reason to intervene. I returned to the room and took a seat near the door, not charting, not scrolling, just watching. I told myself it was good practice to be present. In truth, I didn't want to leave. Time moved strangely after that. Not fast, not slow, just disconnected from the clock. Caleb slept. His parents stayed awake watching him the way parents do when sleep feels like a betrayal. At one point, his mother leaned over and brushed his hair back from his forehead. He stirred slightly, but didn't wake. His breathing didn't change. I remember thinking how normal the gesture looked, how much it resembled scenes I'd witnessed countless times before, and how little it matched what my instincts were telling me. Around midnight, I checked him again. Still breathing, still calm, still no signs of decline. I documented my assessment carefully using the same neutral language I always do. Comfortable, resting, no distress noted. Those words felt inadequate. Shortly after 1 a.m., his father stepped out to stretch his legs. His mother remained by the bed, one hand resting lightly on Caleb's arm, as if maintaining contact might anchor him there. I was standing just inside the doorway when it happened. There was no dramatic moment, no sudden gasp, no visible struggle, no sound at all. Something simply changed. Caleb's breathing slowed, not gradually, but decisively, like a switch being flipped. One breath, then another, slightly farther apart. I moved closer immediately, my attention narrowing to the rise and fall of his chest. His mother noticed it too. She leaned forward, eyes fixed on him, her hand tightening slightly. I watched for signs I've learned to recognize instinctively. Terminal breathing, irregular rhythm, tension in the jaw. None appeared. Another breath came, then another, then nothing. I waited, counting silently, willing his chest to rise again. It didn't. I checked his pulse. Faint, then gone. His mother said his name once softly, not panicked, just hopeful. I placed my stethoscope against his chest, even though I already knew what I would hear. Silence. The entire process took less than a minute. There was no agitation, no final gasp, no drawn-out struggle. Caleb did not appear to wake up. He did not appear to suffer. He did not appear to notice anything changing at all. His body simply stopped. I confirmed what I had to confirm following protocol, even though my hands felt slightly disconnected from the process. Time of death. Documentation, gentle explanation. His mother didn't cry at first. She just stayed still, her hand still resting on him, like if she didn't move, this might reverse itself. His father returned to the room just as I was quietly explaining what had happened. He crossed the space in 3 steps and placed his hand on Caleb's shoulder, as if grounding himself in something physical. The room remained calm. Too calm. There was no chaos, no alarms, no rush of staff. Hospice deaths are often quiet, but this quiet felt different. Compressed. Complete. As I spoke with his parents answering the questions that come immediately after death, I kept replaying the sequence in my mind. The absence of warning, the lack of visible decline, the speed. This was not how hospice deaths usually unfold, especially not in children. I helped them with the initial steps, offering time privacy support. They asked if they could stay with him for a while. I told them yes, of course. When I stepped back into the hallway, the contrast hit me hard. The rest of the building continued as if nothing had happened. Soft footsteps, low voices, a cart rolling quietly past. I leaned against the wall for a moment, grounding myself, reminding my body that this was my job, that death is not an emergency in hospice. Still, my mind kept circling the same thought. This did not follow the pattern. Caleb had not shown signs of imminent death. He had not struggled. He had not declined in a way that prepared anyone in that room for what happened. I documented carefully, sticking to observable facts. Sudden cessation of breathing. No distress observed. Family present. Time noted. But as I typed a different question, pressed in one that had nothing to do with forms or protocols. If this wasn't the expected course of his illness, then what exactly had we just witnessed? I closed the chart and stood up, aware that something fundamental had shifted in my understanding of this case. Not emotionally, clinically. Caleb's death was peaceful, but it was also abrupt in a way hospice care rarely is. And that combination, calm and sudden, didn't sit easily with anything I knew to expect. As I returned to his room to check on his parents again, I found myself paying attention to details I would normally take for granted. The stillness of his body, the quiet certainty of the moment, the complete absence of struggle. This wasn't a drawn-out ending. It was a stop. And the more I replayed it in my mind, the harder it became to accept that this was simply how things were supposed to go. I stayed in the room longer than I normally would after a death, not because the family needed me there every second, but because leaving felt premature. Caleb lay exactly where he had been, his body unchanged except for the absence of movement. His parents sat close, one on each side, touching him gently, as if physical contact might still matter in ways neither of us fully understood yet. Hospice teaches you how to give space without abandoning people. I stepped back, then forward again, adjusting my position based on their breathing, their posture, the subtle cues you learn to read when words aren't coming. His mother finally asked how something like this could happen so quickly. I answered carefully. I explained that sometimes the body reaches a point where it simply stops, especially with neurological conditions, that not every death follows a visible decline, that what mattered most was that he hadn't been in pain. She listened, nodding slowly, but her expression told me she wasn't asking for reassurance. She was asking for coherence. His father asked a different question. He asked if this was what we had expected. That one landed harder. I told him the truth. This was not how I had expected things to unfold. I didn't say it with alarm. I said it plainly, the way people deserve to hear difficult information when there's no benefit in softening it. He nodded once, then looked down at his son. The room remained quiet, but the energy had shifted. This wasn't just grief settling in. It was confusion looking for a place to land. As we talked through next steps, practical things like time paperwork and who to call his mother, asked if there would be any kind of review, any explanation beyond what we already knew. That question doesn't come up often in hospice. Most families arrive having accepted that answers are limited. They expect uncertainty. What they don't usually expect is surprise. I told her that hospice deaths don't routinely involve further testing, but that families always have the right to request additional evaluation. She asked what that would look like. I explained what an autopsy involved, what it could and couldn't tell us, how often it resulted in definitive answers. I was honest about the limitations. I didn't want to offer hope where there might be none. She listened closely, then said something that made the room feel smaller. I don't think he died from what we brought him here for. Her husband looked at her startled, then thoughtful. He didn't dismiss the idea. He didn't argue. He just asked what made her think that. She said she couldn't explain it. She said it didn't feel like an ending that had been building. It felt like something else entirely. I didn't contradict her. From a clinical standpoint, there was no obvious reason to suspect a different cause of death. From a professional standpoint, I knew that families sometimes search for explanations as a way to manage loss. From a human standpoint, I understood exactly what she meant. Caleb's death had not followed the trajectory we usually see. That mattered. I told them I would support whatever decision they made, that if they wanted further evaluation, we could facilitate the process, that if they didn't, that was also valid. They asked for some time to talk. I stepped out of the room and closed the door quietly behind me. The hallway felt unusually bright, like my eyes hadn't adjusted yet. I walked back to the nurse's station and sat down, hands folded, trying to slow my own thoughts. Hospice cases rarely leave me questioning the system itself. This one did. I reviewed my notes again, looking for anything I might have missed. Any sign I dismissed too quickly, any moment where a different choice might have changed something. Nothing stood out. That didn't make me feel better. When I returned to the room, his parents had made a decision. They wanted an autopsy. They weren't angry. They weren't accusing anyone of wrongdoing. They simply wanted to understand what had happened to their child, especially if it wasn't what everyone had assumed. I explained the process again, this time in more detail. Who to contact, what paperwork was required, what timelines looked like. I made sure they understood that an autopsy might not provide clear answers. They told me they understood that too. What they wanted, they said, was clarity, even if that clarity came in the form of uncertainty with a name. I respected that. Arranging an autopsy for a hospice patient isn't common, but it's not forbidden. It requires coordination, documentation, and communication with the medical examiner's office. I handled the calls myself, partly because it was my responsibility, and partly because I needed to stay connected to the process. As I spoke with the on-call physician later, I outlined everything that had happened, sticking to facts. The calm night, the absence of distress, the sudden stop. He listened carefully, then agreed that while this wasn't typical, it also wasn't unheard of. Sometimes, he said, the body fails in ways we can't predict, especially when neurological disease is involved. I agreed with him. I also knew that answer wouldn't settle anything for this family. When I checked on Caleb's parents again, they were calmer, but not relieved. His mother asked if I thought hospice had missed something. The question is one clinician's dread, not because it implies blame, but because it forces you to examine your own assumptions. I told her honestly that I didn't believe anyone had missed a symptom or ignored a sign. I told her that hospice care is built around comfort, not constant surveillance, and that sometimes that means things happen quietly without warning. She accepted that explanation, but I could tell she was holding something back. She said she'd spent years working in healthcare herself. She knew how systems think. She knew how labels can shape decisions. Once a patient is placed under hospice care, she said, everyone assumes the cause of death is already known. She wasn't wrong. That realization stayed with me long after I left the room. Hospice care requires acceptance of limits, but it also carries the risk of narrowing focus too much, of assuming the story is finished when it may not be. As the early morning hours passed, the building slowly returned to its usual rhythm. Staff arrived. Phones rang. Other families needed attention. Life continued in the way it always does, even after a child has died. Before I left my shift, I went back to Caleb's room one last time. His parents were still there, sitting quietly, holding his hands. They thanked me for staying, for listening, for not rushing them. I told them it was the least I could do. As I walked out, I felt the weight of the night settle into something more defined than grief. It was the beginning of a question that wouldn't let go. Caleb's death had been peaceful, but it hadn't been expected in the way hospice deaths usually are. And now, instead of closure, there was a process unfolding that hospice care rarely invites. That realization followed me down the hallway, out the door, and into the cold morning air, where the quiet of the night no longer felt neutral, but incomplete. I woke up later that afternoon with the uneasy feeling that I'd forgotten something important. The kind that lingers even after you check your phone and realize no one is trying to reach you. My body was tired, but my mind hadn't followed. Caleb's room kept replaying in fragments that didn't connect cleanly, like scenes from different stories stitched together. Hospice work doesn't usually follow you home like this. There's a built-in understanding that death is expected, even welcomed in a certain context. You learn to leave it at the door. That boundary didn't hold this time. I returned to Willow Creek the next morning, earlier than scheduled, not because I was needed, but because I couldn't tolerate waiting. The building looked the same as it always did in daylight, calm, orderly, unremarkable. It was unsettling how little the space reflected what had happened inside it. I checked in at the nurse's station and asked if there had been any updates. There hadn't. The medical examiner's office had accepted the case, paperwork was underway, and the family had been informed of the timeline. No answers yet. Just process. I reviewed Caleb's chart again this time, with a different purpose. Not to document care, but to reconstruct the case as if I were seeing it for the first time. I read through every note from his hospitalizations, every consult summary, every diagnostic test that had ruled something out without identifying what remained. The pattern was familiar. A rare condition, progressive decline, increasing uncertainty, medicine narrowing possibilities until only inevitability was left. That's when hospice enters the picture. But now the inevitability itself felt suspect. When the preliminary findings came back a few days later, they didn't surprise me. They disappointed me. No signs of infection, no evidence of aspiration, no acute complications related to his known neurological disease. Nothing that explained the suddenness of his death. The report used careful language, the kind meant to avoid conclusions. Cause of death undetermined pending further evaluation. I sat with that phrase longer than I should have. Undetermined doesn't mean mysterious. It means insufficient evidence. It means the body didn't leave a clear trail. That happens more often than people realize, especially in children. It doesn't make it easier to accept. When the full autopsy report arrived weeks later, I read it slowly, line by line, the way clinicians do when they're looking for something they don't expect to find. Structurally, Caleb's organs were unremarkable. No hidden cardiac defects, no signs of trauma, no inflammation that would suggest an acute process. His brain showed changes consistent with his underlying condition, but nothing that pointed directly to an immediate cause of death. Then there was the genetic testing. The report noted a variant in a gene associated with seizure disorders and cardiac rhythm abnormalities. And it wasn't classified as pathogenic. It wasn't classified as benign. It fell into that frustrating category medicine relies on far more than we admit variant of uncertain significance. A view said it meant the variant might have mattered, or it might not have. It meant there wasn't enough data to say. It meant that in some children, it could contribute to fatal events during sleep, especially in the presence of neurological disease or fever. And it also meant that in others, it might never cause a problem at all. The report didn't say that caused Caleb's death. It suggested it as a possibility. I closed the file and leaned back in my chair, feeling that familiar mix of intellectual understanding and emotional dissatisfaction. This was how medicine often ends, with probabilities, with theories, with explanations that sound complete until you realize they aren't answers. I called Caleb's parents later that day. I'd been dreading the conversation, not because the information was devastating, but because it was incomplete. Telling someone you don't know is often harder than telling them something painful. I explained the findings carefully, avoiding jargon translating uncertainty into plain language. I told them what the variant could mean. I told them what it couldn't tell us. I told them that the most likely explanation was a sudden seizure-related event that disrupted his heart rhythm during sleep. I also told them we couldn't be sure. His mother listened quietly, then asked the question I knew was coming. So he didn't die from the disease that brought him to hospice. I said that based on the findings, it didn't appear to be the direct cause. The disease made him vulnerable, it created the conditions. But it likely wasn't the final trigger. There was a long pause on the line. She said that was what she'd felt from the beginning. Her husband asked if this kind of thing could have been detected in a hospital. I answered honestly. Sometimes. Not always. Even in monitored settings, these events can happen without warning. That didn't make hospice responsible. It didn't make anyone negligent. It just highlighted the limits of prediction. Still, the implication hung in the air. Hospice care assumes the cause of death is already known. Hospital care assumes there's still something to discover. Caleb had moved from one framework to the other at a moment when the distinction mattered. After the call, I sat alone in my office and stared at the closed file on my desk. The explanation we had now fit some of the facts. It explained the suddenness, the lack of distress, the absence of a prolonged decline. What it didn't explain was timing. Why that night? Why that moment? Why a child who had been calm, present, and comfortable hours earlier had simply stopped? Medicine is comfortable with partial truths. Families are not. In the days that followed, I found myself reading more than usual. Articles on sudden, unexplained death in childhood. Case studies involving seizure-related cardiac events. Research that offered correlations without clarity. The more I read, the more familiar the language became. Rare. Understudied. Poorly understood. Likely multifactorial. The same words over and over. What unsettled me most was how easily this explanation could coexist with hospice care without ever intersecting it. Hospice didn't cause Caleb's death. Hospice also didn't prevent it. The systems ran parallel, never meeting, but each operating exactly as designed. That realization made me uncomfortable in a way I couldn't quite articulate. It wasn't guilt. It was awareness. If Caleb hadn't been in hospice, his death would have been categorized differently, investigated sooner, interpreted through a different lens. That didn't mean the outcome would have changed. It meant the story told about it would have. As I moved through my shifts in the weeks that followed, I carried that awareness with me. I listened differently. I hesitated longer before labeling a trajectory as inevitable. I noticed how quickly we stop asking questions once comfort becomes the primary goal. None of this made hospice wrong. It made it incomplete. The explanation we had for Caleb's death was reasonable. It was supported by evidence, limited though it was. It gave the family something to hold on to, even if it didn't provide certainty. For me, it left a different imprint. Caleb's death wasn't unexplained in the way people imagine mysteries. It was unexplained in the way medicine often leaves things unfinished, with enough information to outline a possibility, but not enough to close the case. That kind of ending doesn't feel like closure. It feels like a door that was never meant to be locked in the first place. I didn't think about Caleb every day at first. That surprised me. I expected the weight of it to be immediate constant, the way people imagine trauma works. Instead, it settled in unevenly, showing up when I wasn't looking for it. A child's laugh in the hallway during a family visit. A small pair of shoes by the front door of the hospice. A stuffed animal tucked into a corner chair. Ordinary things that had always been there, now suddenly louder. At work, everything continued as usual. Patients arrived, patients declined, families gathered and said goodbye. I did my job the same way I always had, steady, professional, careful. On the surface, nothing about my practice changed. Underneath, I noticed myself hesitating more often. I spent longer in rooms with pediatric patients, even when there was no clinical reason to. I asked more questions before labeling a trajectory as expected. I found myself paying closer attention to how children spoke, not just what they said, but the confidence or uncertainty behind it. Caleb had spoken with confidence. That was the part I couldn't shake. Not the words themselves, but the absence of fear behind them. He hadn't sounded confused or distressed. He hadn't sounded like a child trying to make sense of something beyond his understanding. He'd sounded settled. I told myself repeatedly that this didn't mean anything supernatural. Children with chronic illness develop a different relationship to their bodies. They notice changes adults overlook. They adapt to limitations long before the people around them do. Acceptance can sound like certainty when you're not used to hearing it from someone so young. I believed all of that. What complicated things were the details that surfaced later. About a month after Caleb's death, his mother called me again, not to ask questions this time, to share something she'd found while cleaning out his backpack from preschool. She told me he'd brought home a drawing a few days before he came to hospice. At the time, it hadn't stood out. Just another piece of paper folded into a bag already heavy with hospital paperwork and unanswered questions. She unfolded it later, after the house was quiet. The drawing was simple: stick figures, one small, one tall, no dramatic colors, no obvious symbols. Just two figures standing close together. What caught her attention was the note at the bottom, written in the teacher's handwriting. "This is me," Caleb had said. "And this is someone who stays with me when it's quiet." She told me she didn't know what to do with that information. She wasn't calling to ask for interpretation. She just needed someone else to know it existed. I thanked her for telling me. I told her it sounded like something a child who'd spent a lot of time being watched might say. I offered explanations I genuinely believed. Children create internal companions. They personify comfort. They use language symbolically when concrete food terms fall short. She listened, then said she understood all of that. But it still feels like he was already somewhere else, she said. I didn't argue with her. After we hung up, I sat in my office for a long time, staring at nothing in particular. I wasn't disturbed by the drawing itself. I'd seen countless examples of children expressing fear, hope, confusion, and comfort through art. What unsettled me was the timing. 3 days before hospice, before any talk of endings, before anyone told him he was dying, before the shift in language that usually signals awareness. Coincidences happen. Medicine is full of them. We notice them more when outcomes are tragic. I reminded myself of that. Still, the image stayed with me. I began to notice how often families search backward for meaning after a loss, finding significance in moments that felt ordinary at the time. It's a human impulse, not evidence of foresight. Grief reshapes memory. It assigns importance retroactively. Knowing that didn't make the image fade. In the months that followed, I spoke about Caleb's case at a team meeting. Not as a mystery, but as an example of how pediatric hospice cases can challenge assumptions. We talked about sudden death, about seizure-related events, about genetic uncertainty. The discussion was professional, grounded, practical. What I didn't share were the conversations. The tone of his voice, the way he'd reassured me. Those details didn't belong in a clinical review. They belonged to something else, something quieter. I found myself thinking about him most often when I drove home after night shifts. The roads outside Asheville are dark and winding, forgiving of silence. I'd replay small moments. His question about whether people stayed when it was quiet. His certainty that things were finished. I never wondered if he'd predicted his death. That's not how I think. What I wondered was whether he'd simply recognized a state of readiness his body had reached before anyone else noticed. Medicine measures readiness with data. Children measure it with sensation. That idea stayed with me longer than I expected. At work, I adjusted how I spoke to families. I stopped reassuring them too quickly. I listened longer when they said something felt off, even if the chart didn't support it. I became more comfortable saying, "I don't know," without rushing to fill the silence. Some of my colleagues noticed. They joked that I'd gone soft, that I was overthinking things. They weren't wrong about the overthinking. They just misunderstood the cause, and Caleb's case didn't make me doubt hospice care. It made me respect its limitations. Hospice is built on the assumption that the primary question has already been answered. Sometimes that assumption is wrong. Not dangerously wrong, just incomplete. I kept a copy of the drawing his mother eventually sent me. Not on display, not framed, just folded inside a folder in my desk drawer. I didn't look at it often. I didn't need to. Knowing it was there was enough. Every so often, usually late at night, I'd find myself wondering whether the calm I'd witnessed was something we could learn to recognize better. Whether readiness can present without distress. Whether peace sometimes arrives before we're prepared to acknowledge it. Those thoughts didn't interfere with my work. They informed it. Caleb didn't haunt me in the way people imagine hauntings. He didn't appear in dreams or intrude on my daily life. He showed up in pauses, in hesitation, in moments where certainty would have been easier but less honest. I continued caring for patients. I continued believing in comfort, dignity, and restraint. I also continued carrying the awareness that some stories don't end cleanly, even when we do everything right. That awareness changed the way I listen. It changed the way I sit in silence with families who aren't ready for answers that don't exist yet. And sometimes when a room grows quiet in that particular way, the way hospice rooms do late at night, I find myself remembering a small boy who taught me that quiet doesn't always mean absence. Sometimes it means arrival. I noticed the change in myself on an ordinary afternoon, the kind that usually fades as soon as it's over. A new patient had arrived. An elderly man with advanced heart failure, his chart clean and predictable in the way hospice charts tend to be. I read through his history, nodded at the familiar patterns, and felt the old confidence rise. Then I paused. I went back and read it again. Nothing was wrong with the case. What had changed was my relationship to certainty. I no longer trusted it the way I once had. Caleb had made that impossible. Hospice medicine depends on acceptance. We accept that the body will stop. We accept that comfort replaces cure. We accept that not every question needs an answer. What Caleb taught me was that acceptance can quietly become assumption if we aren't careful. I didn't stop believing in hospice care. If anything, I became more committed to it. But I became less willing to let hospice thinking flatten complex situations into tidy narratives. And a peaceful death isn't always a predictable one. A calm patient isn't always following the expected path. That realization stayed with me in subtle ways. I listened more carefully when families described things that didn't quite fit. I resisted the urge to explain too quickly. I allowed uncertainty to sit in the room without rushing to smooth it over. Colleagues noticed the shift before I named it myself. One physician joked that I'd become overly philosophical. Another said I asked too many questions for someone whose job wasn't diagnosis anymore. They were right in a way. Caleb blurred a line I hadn't realized I relied on. Hospice is supposed to begin where medical investigation ends. His case reminded me that the boundary isn't always clear. Sometimes investigation ends because we decide. It has not because the questions are finished. I thought about his parents often, about the way they balanced grief with clarity. They didn't blame anyone. They didn't search for someone to hold responsible. They wanted coherence, not comfort. That mattered. Medicine is very good at offering comfort. It is less skilled at tolerating unresolved stories. We prefer conclusions, even tentative ones, because they give shape to loss. A label, even an uncertain one, feels better than none at all. Caleb's death gave us a label: probable seizure-related cardiac event, genetic variant of uncertain significance. It was enough to complete a death certificate. It was not enough to complete the story. I learned to live with that gap. Over time, the sharpness of the memory softened, but it never disappeared. It integrated. Caleb became part of the quiet knowledge I carry into rooms where families are trying to understand what is happening to someone they love. I don't tell his story often. When I do it, it's not as a mystery or a cautionary tale. It's an example of how, even when we do everything right, the outcome can still surprise us. Not because of failure, but because of complexity. Medicine doesn't like complexity unless it can be measured. Hospice ironically lives inside complexity every day, yet often avoids questioning it. Caleb forced me to sit at the intersection of both. I became more comfortable saying this may not follow the pattern we expect. I became more honest about what we don't know. Families respond better to that than we give them credit for. Uncertainty shared feels lighter than certainty imposed. I still believe comfort is a worthy goal. I still believe restraint can be ethical. I also believe vigilance doesn't end when we stop monitoring vitals. Sometimes it begins there. There are nights when I walk past a pediatric room and feel the echo of that quiet again. Not fear, not dread, awareness. The understanding that calm does not guarantee predictability. I never came to believe Caleb knew exactly what was happening to him. I don't think he predicted his death or understood it in adult terms. I think he noticed his body changing and responded to it. Honestly, without the layers of denial adults rely on. Children don't explain things the way we do. They describe experience. Caleb described completion. That doesn't require foresight. It requires presence. That distinction matters. I still keep the drawing his mother sent me. It stays folded, out of sight because it isn't a symbol for me. It's a reminder. A reminder that meaning doesn't always announce itself when it arrives. Sometimes it waits until you're willing to look back without forcing it into a shape that makes you comfortable. Hospice work hasn't become harder since Caleb. It's become quieter. I'm less interested in filling silence with reassurance. I'm more willing to let families speak into it. Silence carries information if you don't rush past it. When people ask how I handle cases that stay with me, I tell them the truth. You don't handle them. You integrate them. You let them adjust the way you practice without letting them paralyze you. Caleb adjusted me. He didn't change the outcome of any future case. He changed the way I pay attention. That's a small shift with a lasting impact. I still believe medicine saves lives. I also believe medicine reaches its limits more often than we like to admit. Hospice exists at that boundary, and Caleb showed me how thin the line really is. Some deaths arrive the way we expect, some don't. The difference matters not because it assigns blame, but because it shapes how honestly we approach the next family who asks, is this how it's supposed to happen? Sometimes the most responsible answer is that there is no supposed to. Caleb's death was peaceful. It was sudden. It was incomplete in explanation and complete in finality. Holding all of that at once is uncomfortable, but it's also real. I continue doing this work because I believe in it. I also continue because I understand it better now, not as a system that explains everything, but as one that must coexist with unanswered questions. The child who arrived in hospice and died without warning didn't leave me with fear. He left me with humility. And in medicine, humility is often the most honest thing we have. Some cases don't end when the paperwork is finished. They stay with you in quieter ways, shaping how you listen, how you pause, how you respond when families ask questions that don't have clean answers. Working in hospitals and hospice care has taught me that medicine is powerful, but not complete. Doctors and nurses do our best within systems designed to help. Yet there are moments when the most honest thing we can offer is presence, humility, and the willingness to admit what we don't know. Caleb's story reminded me that real nurses' stories and doctors' stories aren't always about saving lives. Sometimes they're about witnessing them with care when medicine reaches its limits. If you value real hospital experiences and true doctors and nurses' stories that go beyond charts and diagnoses, consider subscribing to the channel. These are the stories healthcare workers carry with them long after the shift ends, and sharing them helps keep the conversation honest.